Good evening to you, Dr. Waf.
How are you?
Good, good. Thank you so much for organizing this and having me over.
Thanks for your cooperation.
Of course.
I'm eagerly waiting for the lecture.
Sure, of course. I'm happy to do so. We'll wait a couple more minutes, right? For people to
Yeah,
join in. Yeah.
yeah.
I'm going to be back in 1 minute. I'm just going to get some water.
Dr. Baha, you are with us? Okay, couple of minutes and we begin, Dr. Baha.
Dr. Wafa, you'll let me know when to start.
Yeah, okay. Good evening, everyone. I will introduce Dr. Prasad Deshpande. It's my great pleasure and honor to welcome him. He is the medical director of the Advanced Cardiac Therapies Program, Children's National Hospital, and professor at George Washington University Hospital in Washington. Dr. Deshpande is highly respected expert in pediatric cardiac care and advanced cardiac therapies with extensive clinical and academic experience. We're truly grateful that he accepted our invitation to share his knowledge and experience with us today. Sessions like these are a valuable opportunity for continuous learning and professional development. We are much looking forward to benefiting and from his insights and expertise. Thanks, Dr. Shepard, for joining us today. The floor is yours.
You're welcome. Thank you so much. It's an honor to be here with you. And I'll quickly share the screen. And okay. Yeah, thank you again. And again, I've kept the actual presentation quite general. And I'm hoping that people can either ask questions in the chat box or at the end of the talk. I don't mind being interrupted if you want to. But my hope is to just give you a general overview of myocarditis in children, and then give you some insights into what we can do about it and what are the new things to keep in mind as we take care of some of these kids. So thank you again for the invitation. The goal for the talk today is pretty straightforward. My goal is to empower ourselves so that we do not miss one single case of pediatric myocarditis. And then the reason for this is because if we help them in time, majority of these kids will survive. If we misdiagnose them, majority of them do not survive. So I think the biggest reason for mortality in pediatric myocarditis is the lack of timely diagnosis. That's it. If we can get these kids to be diagnosed in a timely manner, we can support them through it. So that's why I feel so passionately about not missing a single case of myocarditis. So that's a lofty goal. It would be really nice and convenient if we were asked to pick out the white koi fish in a pond of an orange fish, right? If myocarditis was like that white koi fish, was easy to spot, it would be really easy and it would be convenient, and we will not miss the one white fish in there. But it's not like that. And myocarditis, unfortunately, is a disease that will not allow us an easy diagnosis, and that's why we need to talk about it. Let's review the clinical background. We'll quickly talk about some diagnostic approach, and we'll briefly mention the importance of stabilization and therapies. And in doing so, let's try and identify something that's actionable, modifiable within each of these categories. So what is myocarditis? As everybody knows here, inflammation, apoptosis of myocardial cells with or without necrosis. And the necrosis is the irreversible part, as we know, but inflammation is the central necessity of the diagnosis of myocarditis. On histopathology, this is what it looks like, very straightforward. As you see in the middle of the picture there, you have an active inflammatory infiltration. But that's not the problem. The problem comes from the myocytes. And if you pay attention to the myocytes, the cardiomyocyte arrangement in that histopathology picture, you will see that there is disruption of how tightly knit myocardium is supposed to be, and it is not. So this infiltration, edema, and disruption of the tight bonding between the myocytes is what causes the problem too. So that is myocarditis for us. So let's talk a little bit about the etiology. We generally think that we underestimate the incidence of it, mainly because the significant number of cases that are subclinical in nature that don't ever get the label of myocarditis is very, very high. On the other spectrum, 6 to 12% of patients with myocarditis will present with sudden death or sudden death event, such as cardiac arrest. There is a male preponderance, certainly more male than female. And what we do know about the etiology is that viral myocarditis, again, in the clinical spectrum, is the most common reason for myocarditis. Autoimmune post-viral immune-mediated myocarditis certainly play a role. And drugs and toxin-mediated myocarditis is also very well documented. But for all practical purposes, we are going to focus mainly on the viral myocarditis part of it. And just to give you a spectrum of biological myocarditis, so this is viral, bacterial, fungal, spirochetal, protozoal myocarditis. This is a very, very long list. And we compiled this list when we were working on the AHA statement on pediatric myocarditis, which I'll reference later. But it gives you a sense that this is an extensive list, which also means that pretty much any clinically relevant pathogen has been associated with myocarditis. So in the back of our mind, I always want us to have this as a differential diagnosis whenever we are dealing with any of these known pathogens. Certainly the left column, which is the viral myocarditis column, viral pathogen column, that's the most common that you'll see clinically. Of the viral myocarditis, the current epidemiology states that Coxsackie-B, adenoviruses, parvoviruses, and enteroviruses are the most common reasons for viral myocarditis. Of course, during the COVID era, we had COVID as a very significant contributor to viral myocarditis too. But in pediatrics, these are the 4 common families of viruses that are responsible for a majority of the clinical cases. The viral myocarditis goes through 3 phases of pathology. First phase is the viral infection pathology. Second phase is the autoimmune injury. And third phase is the remodeling. In the viral pathology phase, bear with me for this one, because this is actually quite interesting and important. All of the viruses, or majority of the viruses, will have their own portal of entry, as we know. We know some viral pathogens as gastrointestinal, we know some as respiratory viruses, but the cardiotropic viruses, which means the viruses that do want to go and attach themselves to the heart, the cardiotropic viruses, even those have different port of entries. So, for example, Coxsackie and adenoviruses, again, 2 of the more commoner viruses, they have direct receptors onto the myocardium itself. And those receptors are called CAR, or Coxsackie adenoreceptors. These are present directly on the myocytes, and the virus that is circulating in the blood can directly attach to the CAR, the Coxsackie adenoreceptors, and induce myocarditis right away. Whereas there are other viruses that traverse through lymphoid tissue primarily. And the examples of those are going to be things like CMV, cytomegalovirus, or herpes virus. These go through the lymphoid tissue and secondarily get attached to the myocardium and will cause myocardial injury. There are also other viruses, such as, for example, parvovirus, that has greater affinity to endothelial surfaces. And so parvovirus, for example, will have a significant portal of entry through the blood vessels and the smaller capillaries within the heart and cause injury from there on. Independent of the portal of entry, as I said, every virus may have a slightly different port of entry. What we do know is that there is a significant overlap from there on with DAF, which is decay activating factor. Again, another receptor that is present on the myocardium that can bind a variety of viruses also. In the classic sense, DAF and coxsackie-adenovirus receptors together will increase the likelihood that the virus particles or the viral genome, it gets intracellularized. So now the virus is able to traverse from the bloodstream or other tissue, like lymphoid tissue, into the cell of the myocyte itself. So now the virus is in the cardiomyocyte. And once we get there, then in doing so, it is going through these three phases quickly: the attachment phase, the collaboration phase, and the internalization phase. Once the viral genome is internalized into the cardiac myocyte, then you have a series of actions that get triggered. And these are the immune phase of the pathology. The virus itself can cause direct myocyte death or injury, but it also causes a lot of pathology from the immune phase or the inflammatory phase of this infection. This occurs through direct activations of the signaling pathways or through MHC-restricted pathogenic mechanisms. But in the end, what you end up with is a profound inflammatory phase, which results in a lot more injury, both in the local area, so the cardiomyocytes, as well as systemic inflammation and injury. This can be described also as an autoimmune phase, because in the autoimmune phase, there is self-injury that is occurring throughout the body as a part of this inflammatory response. So the IL-6 and the interleukins that are getting released are all activating further downstream factors such as, say, TNF-alpha, and these cause systemic injury and cause local injury. This autoimmune phase can persist even when the viral replication phase has ended already. And as I mentioned, this can lead to, again, cytokine activation and creation of cross-reacting antibodies, autoimmune phase, that leads to further injury. This is the immune mechanism or the immune phase of viral myocarditis, which can occur after the viral phase or the viral replication phase has already ended, which means that this can last for a much longer period of time. This phase of acute inflammation can manifest then itself as such profound injury that all we get is acute sudden death, acute fulminant myocarditis leading to death. Or more commonly, we could get resolution of this phase. So you go through an inflammatory phase, the inflammation subsides, the viral replication subsides, and the body is able to heal itself, leading to resolution of myocarditis. Or you could end up with a chronic inflammatory phase, like we alluded to at the previous slide, the autoimmune phase, which can cause chronic inflammatory changes and manifest itself as dilated cardiomyopathy down the line. So these are various clinical results of the pathology of viral myocarditis. The big question here, however, is that can we predict which way our patient is going to go? Once we acute inflammation, we know, but can we predict whether the patient is going to go through death or resolution or transition to a chronic inflammatory phase? The answer to that does depend a lot on the genetic predilection of the patient itself. So we do think that there is some cross-reactivity between the genetic predisposition to how much cardiotropy a virus can demonstrate, as well as the injury that can occur. So both the likelihood of you manifesting a myocarditis, as well as likelihood of having a fulminant course after that, does seem to have some underlying genetic contribution to it. Either ways, though, as a clinician, what you are worried about is the extent of myocardial injury or the acute change in loading condition that is occurring at that time. And so what we think at this contributes to this is the primary myocardial injury that we just looked at from pathology standpoint, as well as the secondary excessive metabolic demand that is occurring because the patient also has systemic inflammation at the same time. So you are sick, therefore your metabolic demand is high. And this injured heart cannot meet the higher metabolic demands, and it cannot sustain itself either. And as we know that myocardial injury creates or begets itself, which means myocardial injury causes more myocardial injury. And this is one of the most unique scenarios within the body where an organ can injure itself, right? So we know this cycle of events that occurs. Once you have myocardial injury, there is decreased cardiac output. We know about the sympathetic activation that takes place. Those are compensatory changes. In short term, they are life-saving. However, in long term, we know that this leads to the increased in vascular resistance, increased oxygen consumption, as well as the systemic inflammatory response, the SEERS, which then leads to decreased cardiac output. So myocardial injury can actually cause more myocardial injury. And when this cycle is not broken, then this leads to acute decompensated heart failure, which will manifest itself as a shock state. And so our job is therefore to identify and disrupt this cycle from occurring. However, as we alluded to right at the beginning, there is not a single diagnostic sign or a symptom that will tell us that your patient has myocarditis. So our job is therefore to make a clinical diagnosis. This is a clinical syndrome, and we have to identify it based on the entirety of the data. Again, not a single diagnostic test or sign or symptom to pick up myocarditis. So let's look through the clinical features, and myocarditis is often described as the best mimicry artist. In newborns, for example, the symptoms will mimic sepsis. Children will present with poor appetite, irritability, listlessness, pallor, diaphoresis, or sudden death. And as you can imagine, your first diagnosis in the urgent care or in the emergency room is going to be neonatal sepsis until proven otherwise. And you're probably right in thinking about it 99.99% of the time, right? But the point here is that we always need to have myocarditis in the back of our minds. On physical examination, you will notice again clinical signs and symptoms that mimic sepsis: pallor, mild cyanosis, tachycardia, tachypnea, and liver enlargement. In older kids, children and adolescents, lethargy, decreased appetite, abdominal pain, poor exercise tolerance are the most common presenting symptoms. Again, very non-specific symptoms. So if you have a teenager that is presenting to you and complaining of lethargy and decreased appetite, that could be a normal teenager just complaining about things, But it really, therefore, is very hard to separate out early myocarditis from very general symptoms. Symptoms that are respiratory or syncope or sudden death in teenagers are very late in the course, which means that this is a very advanced myocarditis. If you're having syncope as a presentation, you're already in trouble by that time. When we do the physical examination, the most classic sign of myocarditis, suspecting myocarditis, is resting tachycardia. There are going to be 2 or 3 things I really want you to remember out of today's talk, and this is one of them. Resting tachycardia in a teenager who's complaining of lethargy and decreased appetite should not be ignored. It is a very, very important sign of something wrong with the heart, and resting tachycardia in a teenager is very classic. I would say that in my experience, we've seen hundreds of myocarditis. Almost every time, if it's a 14-year-old who gets diagnosed with myocarditis, their heart rate is 110. Their heart rate is not sitting at 60s and 70s or 80s even. Most of the time, their heart rate is 100, 110. So resting tachycardia is a very important sign. They'll have jugular venous distension. They may have some rales or auscultation. And if good auscultation, you may detect an S3 gallop on these patients. This is an older study that looked at pediatric patients presenting to the emergency room with suspected myocarditis and new onset of heart failure column. If you look at the middle one, what you'll see is that at the bottom, at least having one respiratory sign or symptom and one gastrointestinal sign or symptom would account for 80 to 87% of these kids. Again, for a new onset heart failure with myocarditis, respiratory or GI signs and symptoms are very, very common, and those are the ones we need to pay attention to. Further, when you look at the signs and symptoms, so not history, signs and symptoms, tachycardia and tachypnea has much lower sensitivity to it. So only about 50 to 60% of them presented it. But again, like I said, resting tachycardia has high specificity to it. So if you see resting tachycardia, definitely worry about this. We know about the 4 cardinal signs of heart failure: tachypnea, tachycardia, and then further down the line, liver enlargement and cardiomegaly. Out of this, the top 2 are going to be common in myocarditis. So therefore, pay attention to pulses. So both the volume of the pulse as well as the rate and the perfusion of the patient at low cardiac output stage. And with that, we should be able to pick up majority of them. Now, if you add in one GI or respiratory symptom to a patient who has poor perfusion or slightly decreased capillary refill and has pulses that are either thready, low volume, and tachycardic, then you have a very high suspicion of myocarditis in this setup. So I said we'd review the clinical background, diagnostic things. Now let's talk about specific diagnostic approach as well as therapies for these patients. Again, it's not going to be as easy as picking out the red frowny face in a sea of smiley faces, right? So what does it take? It takes high index of suspicion. Your diagnosis is based on high index of suspicion alone. So unless we think about it, we're not going to see it. Just to summarize, in infants, it will mimic sepsis, and in older kids, it may mimic viral syndromes, random aches and pains, or it may even mimic asthma with the respiratory symptoms. Laboratory diagnosis, you're going to get CBC, chemistries, and blood culture drawn because you're worried about infection anyways. CKMB and troponin are cardiac markers, but again, the likelihood that you would draw them in a patient where you suspect sepsis or something is very low. In fact, most troponins get drawn after a point of care or an ultrasound or an echocardiogram was already done. No? It's very rare for troponin in pediatric patients to be the first test that is done. But if it is done, it will show an elevation. The reason I have an asterisk over there is because the current troponin that is available in most emergency rooms for adult diagnosis of coronary pathologies, myocardial infarction, ischemic heart disease, is a high sensitivity troponin. And high sensitivity troponin can be increased in almost every single clinical scenario in pediatrics that you can think of, including sepsis. So it's not going to allow you to differentiate myocarditis from sepsis-related toxicity in general. So it's an extremely sensitive thing, which means it is very low specificity in this case. BNP, or brain type natriuretic peptide, is another laboratory marker that we'll talk about in the next slide. So let's talk about brain type natriuretic peptide. Now, brain type natriuretic peptide, in my view, in acute heart failure symptoms, is our bread and butter. We think the next best thing since sliced bread. It is secreted by atrial and ventricular myocytes, and the action of brain type natriuretic peptide is natriuresis, excreting sodium in the urine, diuresis, vasodilation, and smooth muscle relaxation. Now, if we go back to our primary pathology diagnosis, that's the circular diagram that I showed you. The first response to acute decompensated heart failure was sympathetic activation, right? You have cholinergic action, you have the activation of the RAS system, renin-angiotensin-aldosterone system, as well as secretion of epinephrine, norepinephrine. All of those actions led to everything that is opposite of what the BNP is trying to do. In other words, BNP is the opposing hormone that balances all of the other hormonal actions that are occurring during acute heart failure because of the sympathetic stress response that you saw. So with renin-angiotensin system, you want to hold on to water, you want to hold on to salt, you want to cause vasoconstriction, etc. And BNP is doing exactly opposite things. So in our milieu, in our homeostatic mechanisms, we don't have unopposed action of hormones in the body. There's always a counteracting presence, a chemical that's present. And BNP is that really important chemical for us. But it's an extremely important biomarker for us in acute heart failure. So in myocarditis, BNP is our test of choice. It's a high-value test in evaluation of suspected cardiac disorder. High sensitivity and specificity for acute heart failure or ventricular stain that is occurring. Most importantly, it is a point of care test. So the same cartridge, the same handheld device that can run your blood gas, for example, in the emergency room or in the ICU, can also run BNP test. It's essentially the same thing, you just use a different cartridge. So there is really no excuse for us not to do BNP very early. In fact, I started proposing use of BNPs back in 2007, 2008. And we made it to the point wherein our flight crew, not just our hospital's flight crew, but our regional flight crews, when they would go out in response to a patient, a pediatric patient, they started carrying BNP cartridges with them, not just a blood gas cartridge. No? So the emergency responders could go to the field, they could stick the patient, if they're sticking them for a blood gas, they would run a BNP, because if the BNP was elevated, that patient needed a very different transport to be taken place, a different destination, versus a patient that just requires go to the local emergency room to get treated for sepsis or other reasons for being lethargic or something. But if the BNP was elevated, that patient needed to be transported quickly to a quaternary hospital if possible, even if it meant 10 minutes of an extra flight. So it is an important test that I really wanted to. So the second thing I really want you to remember is to get BNP and get BNP early in the diagnostic pathway. Ultimately, like I said, it's a clinical diagnosis. Patients often will present with florid respiratory distress syndrome type x-rays because their heart is so stunned that their lungs are flooding. So they develop acute pulmonary edema. This patient might get diagnosed as ARDS secondary to a viral infection or something. We always have to have myocarditis in mind. There are other situations wherein you might see just heart enlargement or the cardiac silhouette being big for the size of the heart, for the size of the chest. And this may be a combination wherein it's not necessarily a dilated heart, but it may also be acute myocarditis with pericarditis or pericardial effusion occurring. So could be cardiomegaly as a presentation, or could be just a wet X-ray on the appearance, should tip us to this. This is just an example of how bad the lungs can get in myocarditis. Obviously, this patient came in, got rapidly intubated, and as you can see, the lungs are already fully wiped out in this patient. So sometimes the focus can be on the lung fields, where the primary diagnosis is the heart. EKG. EKG can be helpful in some cases. Again, the high specificity, low sensitivity. This is a 16-year-old with 1 month of cough and fatigue. And what is remarkable on this is, again, low voltages mainly. And what you don't see is very significant arrhythmias or very significant changes on the EKG. But what you do see is atrial enlargement and low amplitude EKG. Here is a 9-day-old with feeding intolerance for 1 day only, and came in with florid arrhythmias. But it turned out that the arrhythmia was only secondary to a full-blown myocarditis in this patient. BNP again was very, very elevated. This is about, in this laboratory, less than 100 BNP would have been normal. So this is more than 43 times elevation. echocardiogram, whether it's point of care ultrasound or echocardiography, is really the key to diagnosis. I'm not going to play these images, but just to show you quickly, when you look at it, you can clearly see pericardial fluid collection, and you'll see decreased function of the heart. So this is an acute process occurring. The heart is normal in size, hasn't enlarged. The myocardium itself looks thickish, which is because of the edema, but there's already acute inflammatory fluid that is collecting, very classic for myocarditis. Or in a four-chamber view, you might see that the function is down. This patient does not have pericardial fluid collection, but all you see is a normal size, normal shaped heart with severely decreased function. And over time, this is what that same heart might look like. This is a fully remodeled myocarditis in its chronic phase, where the virus has already gone away, but the injury to the heart is now manifesting itself as a dilated cardiomyopathy, and the patient may present in this stage. Viral PCR as a part of the diagnostic algorithm are important, so please run the viral PCR if you can run it, whether it's through the nasal swab or any other mechanism that you can run through. Because identifying the virus helps us treat it appropriately. The gold standard for diagnosis of myocarditis continues to be biopsy. Biopsy, as I showed you right at the beginning, will show you the classic infiltration and show you the classic picture of myocarditis. What is really important is that we send these myocardial biopsies for PCR also, because identifying the virus that led to the myocarditis in a biopsy is really important because it can dictate how we treat this patient. Really, really important is that it will give you differential diagnosis. Rather than thinking about a classic myocarditis, you may find that the patient actually has giant cell myocarditis. And giant cell myocarditis, which can only be diagnosed on a biopsy, has a very different prognosis and a very different treatment algorithm. So unless we had the biopsy, we wouldn't have been able to diagnose a patient with giant cell myocarditis. Similarly, eosinophilic myocarditis is another example wherein biopsy can dictate eosinophilic infiltration, which will change our treatment completely for those patients. And that can occur without peripheral eosinophilia. So in my view, biopsy in a myocarditis is critical, and when available, we should always do it. Cardiac MRI obviously has a role, and both in the acute phase and a chronic phase, it can show inflammation, edema, as well as lead gadolinium enhancement, which is again changes in perfusion and viability of the myocardium. And in late phases, it will show myocardial scarring. So cardiac MRI does have a place in acute diagnosis. However, when the patient is really sick, we will not put that patient into cardiac MRI. We would rather treat them based on a clinical diagnosis because, again, doing a cardiac MRI, about a 45-minute test, sometimes can be quite challenging in sick patients. So we do not use necessarily cardiac MRI for primary diagnosis of myocarditis. However, when we wrote the AHA statement on pediatric myocarditis, and I would really encourage you to take a look at this one. It really is a very comprehensive document. We, for the first time, therefore, wanted to change how we think about myocarditis diagnosis and start to use same language, because the challenge with myocarditis literature often is the language in terms of how the diagnosis was reached is quite complicated. So we propose this pyramidal structure wherein at the top of the pyramid is still biopsy. Biopsy-proven myocarditis is still the language we want to use. MRI, cardiac MRI, confirmed myocarditis would be the second tier of diagnosis. And at the bottom, baseline is clinical diagnosis of myocarditis, which is suspected or possible myocarditis based on the clinical diagnosis itself. That is adequate. But we just want to use consistent same language when we talk about myocarditis. So in the last 5-10 minutes, let's quickly go through the treatment. The goals of therapy are normalization of the altered hemodynamics. And second goal is to ameliorate the symptoms itself.
Doctor, could we ask questions at the investigations before going through treatment?
Absolutely. Please go ahead.
What do you think about the index of CK and CKMP in prognosis of myocarditis? Could we rely on just CK and CKMP if they are high in diagnosis of myocarditis, if no available pro-PNP?
Absolutely. And again, if you are thinking about myocarditis and you have elevated both CKMB as well as troponin, that to me is the next best substitute for diagnosing myocarditis. Then you can certainly use them as a trend also, whether the trend of myocarditis of the CKMB troponin is going up, going down. Like I said, the only problem I have is that troponin, because the test is designed to be is calibrated for adult myocardial ischemia, the
Yeah.
levels of rise that we see in myocarditis of troponin specifically are so high, they are so beyond what the test is designed for performance-wise, is that a BNP for a troponin, for example, going from 800 to 1200 may mean nothing, you know. It doesn't
Yeah.
mean that the troponin has increased significantly. So long as we are paying attention to it appropriately, I think it's okay, because troponin of 8 would be a massive heart attack, you know. Or 80 would be a massive heart attack. If you are using high sensitivity, 60 is normal. 80 would be very high index of MI already. We're talking about 800 troponin, and I've seen troponins in 25,000 range, you know.
Yeah.
So long as we use that, that's fine. What I would, however, encourage is to ask the question, because the BNP is so cheap and so easy to do, as to, if you have access to CKMB and if you have access to troponin, why can you not get access to BNP? Is a question I want everybody to ask, even at this smallest of the labs, because it is so easy to do and it is so cheap relatively.
No, yeah, sometimes we have no PNP. From what I get, we are not talking about an absolute number for troponin or CK-CKMP. It's a trend. Am I correct?
Yes, exactly right. Yeah, they are going to be abnormal, and then from there on, you just trend them.
What is the most important to get early knowing the diagnosis of myocarditis? Is it clinical symptoms or doing the labs? What if the labs is not consistent with the clinical?
Yeah, I think having the clinical suspicion trumps everything. So what I want people to always think about is to think about myocarditis first, because once you think about it, you've already done yourself a big favor in terms of ruling it in or ruling it out, right? Then you can look at what test should I be ordering, and look at the test in an appropriate. So we talk about, you know, what's the likelihood that the test is going to be helpful. If you could order 100 tests for every patient, you just create basically data misery. You know, you just have 100 tests, now you don't know what to do with them. That's not been our classic teaching, right? We want tests to be ordered appropriately so that you had something in mind, you had a differential diagnosis in mind. So always say clinical suspicion trumps everything. So if you are thinking about a diagnosis, think about myocarditis, and then say, well, I'm going to order the blood culture, I'm going to order a CBC, I might even order the antibiotic dose. But I also want, because I'm worried that this might be subtle myocarditis, I'm going to order a troponin level or something like that. I think that's completely appropriate. But I would want people to be thinking about it clinically first before we jump to the testing.
Okay. Also, I want to ask about clinical. Is every myocarditis must have hepatomegaly with it or not? It is not a must.
No, it's less than 50% and only in little kids, because then you can see a little bit of a right heart congestive symptoms early in little kids. In kids that are over a year of age even, unless that kid the most common reason why patients with myocarditis have hepatomegaly is not because of the pathology. It's because somewhere along the way they got massive volume resuscitation. That is the most common reason why they get hepatomegaly. So patients come in, they behave like they have sepsis, and our emergency room physicians are well trained to resuscitate patients with suspected sepsis with massive volume and 10 per kilo, 20 per kilo. And patients with myocarditis cannot handle volume at all. Immediately, they will put that volume in other spaces. The left heart will put all of the volume that you gave into the lung fields, into the pulmonary edema, and the right heart will put all of the volume you gave into the liver. So the lung and the liver end up getting congested, and the X-ray that I showed you is a classic X-ray post-resuscitation. So well-intended resuscitation ends up congesting the organ right beforehand, which is either lungs or liver. And that's the most common reason why we see hepatomegaly. But otherwise, no, it's not a classic or an early sign of myocarditis.
Okay. What about tachycardia out of proportion to fever? Is this considered an early or diagnostic sign of myocarditis before even labs get through?
Yes, 100%. I would say resting tachycardia that is out of proportion. I would always worry about saying it is now my responsibility to rule out myocarditis. And I'm going to at least think about myocarditis for the next 12 hours for this patient, because it's unlikely you're going to send that patient home for the next 12 hours. Even if the lab is late, I'm already thinking about it. That's the most important part, right? Because that means you're already thinking about how appropriately to resuscitate this patient, how appropriately to manage this patient. What is it that I'm looking for next as a manifestation of myocarditis, even if I don't have any labs with me, right? So then you're at least thinking in the right way, and you're looking out for the right deterioration to occur. So resting tachycardia, you're right, is a very, very important sign that should always trigger at least a thought process that says, I am looking out for decompensation here.
Okay, thanks, sir. Thanks a lot.
Okay. So we'll start with specific therapies before we go to the general dictums that I was mentioning up in the front here, which is the normalization of altered hemodynamics and amelioration of symptoms. Again, how to treat an acute decompensating patient, that could be a separate talk. And you are very well versed with it. Like I was suggesting, my biggest request to you is whenever somebody is thinking about myocarditis, please be careful about fluid resuscitation. That is one thing that can actually harm the patient more than help the patient. So that's my only request in the general sense. Specific therapies wise, immunoglobulin or IVIG is an important component of therapy, and I'll discuss that a little bit. There is considerations for steroids, chemotherapeutic agents, and plasmapheresis when available. Let's talk about IVIG. There is a Cochrane collaborative review on pediatric and adult myocarditis and IVIG use. And if you look at that review, what you'll see is that in general, all of these favor immunoglobulin therapy. And the outcome for this assessment is in-hospital mortality. So if it is suspected myocarditis and in-hospital mortality is your outcome, use of immunoglobulin therapy in general is favorable. However, when you actually look at the odds ratios for all of the studies in the middle, all of them cross one, almost all of them cross one, which means that they are statistically not significant studies. But in general, they tend to favor immunoglobulin, and no study has shown immunoglobulin associated with harm. Some time ago, we published a multi-center study of pediatric myocarditis and looked at the use of IVIG in that cohort. And what I'm showing you here is that what we saw was something unique. This was a retrospective study of 6 US centers. what we saw is that the IVIG use was specifically in patients that were significantly sicker, right? So for example, the ejection fraction on admission for IVIG group was 35% compared to 52% who did not receive IVIG but had a diagnosis of myocarditis, confirmed diagnosis. So clearly we are thinking about using IVIG in a much sicker cohort of patients. Their admission BNP was higher, their peak BNP was higher, ESR was higher, troponin was higher, tenfold higher than this. So we are using it in a sicker cohort of patient. But what to us was much more interesting is if you look down here, the MRI with inflammation was equal and the p-value was not significant. So 60 or 70% showed MRI consistent with inflammation, which meant that 30 to 40% did not show an MRI, but again, met the diagnosis of myocarditis with a very decreased ejection fraction. I wanted to pay attention to this part, which is then when we looked at that cohort down the line, wherein the cohort that did receive IVIG, for example, what we saw is that the rate of death in IVIG group, 2.6%, was similar to death to the group that did not receive IVIG, which was 3%. So 2 to 3% mortality in this cohort. Remember that the cohort that received IVIG was actually quite sick, was much sicker cohort. So when we wrote this analysis, we were thinking whether, again, we can't prove that IVIG is beneficial because it's a retrospective study. But what my takeaway from this was that when sick patients received IVIG, their outcomes were then comparable to not sick patients that did not receive IVIG, or relatively less sick patients that did not receive IVIG. But again, this is not the way to study the efficacy of IVIG, but just an observation. The role for immunomodulator steroids is controversial, and there is data that supports very small studies that support use of steroids, and others where it does not support the use of steroids. Certainly during the COVID era, however, use of steroids was associated with improved outcomes. Use of cyclosporin, azathioprine as second-line agents has been proposed, however, is not really indicated at this time backed by therapies as a first-line or even second-line therapies for that matter. So there has to be very specific indications such as giant cell myocarditis for us to want to use higher grade immunomodulators or immunosuppressive agents. Specifically, using immunosuppressive agents, you have to be careful. If there is persistent viremia, then that can be worse when you use immunosuppressive agents. So very specific indications for use of these agents. In general, no clear benefit. Use of plasmapheresis in a very acute stage, especially fulminant myocarditis, is an important consideration and can reduce the inflammation and viremic burden in that patient. So in the very acute phase, if possible, if we have access to use, consider use of plasmapheresis. Under specific therapies, however, we have gotten much more interested in use of specific antiviral agents now that more and more agents are becoming available for specific therapies. So that is why at the beginning I said having virus identified is very, very important, whether it's through viral PCRs or through the biopsy, PCR of the biopsy, because depending on the agent, we can now use specific antiviral agents that can target the virus itself. So that has been true now for us for parvovirus infections, adenoenteroviruses, and certainly for CMV, herpes, and influenza. I'm leaving out COVID, obviously. So all those viruses have very specific antiviral agents that can be used. A good example is cidofovir that we have increasingly used in acute viral infection myocarditis. So keep that in mind, that it is important to have a virus identified. What is really, really critical is equally important is stabilization. Early and appropriate stabilization of the patient is really important. And intubating the patient early to achieve hemodynamic stability, as you are very well aware, to decrease the metabolic demand, is a really important step. But again, be careful when we do that, because intubation, sedation, and the paralysis required can also decompensate that patient very acutely, lead to a cardiac arrest. So these are very high-risk intubations that should be performed with experienced providers only, experienced physicians who know how to manage these situations. Correct acidosis electrolytes, remember oxygen delivery, both how much to deliver and to reduce metabolic demand of the oxygen delivery itself. And once you are intubated, then certainly there's a role for adjuvants like sedation and paralysis to decrease the metabolic demand and appropriately manage the oxygen delivery deficits. One of the most important things that we found when we studied myocarditis and timing of ECMO use as a rescue measure was the timing of ECMO. And what we looked at was patients who did not have a cardiac arrest prior to intubation and then went on to require ECMO after intubation. The time difference between intubation to ECMO was an important predictor of the outcome of the patient. So, which meant that if you intubated the patient and went on ECMO very quickly, say within 1 hour or within 2 to 4 hours, versus you intubated the patient and 12 hours later, the patient went on ECMO, the outcomes are very, very different. And what we found is that early escalation after intubation had the best outcomes. So the first two top lines, blue and red, and delayed ECMO after intubation had significantly worse survival after discharge. And as you can see, delayed after 18 hours had less than 50% survival to discharge. Whereas the ones that were initiated early within the first 4 hours had a greater than 80% survival to discharge. So what this tells us that a patient with myocarditis who requires intubation has a high likelihood of continued cardiac decompensation. And therefore, we should think about escalation of care early in these patients, because otherwise these patients will progress. And some of them, obviously, the ones who end up requiring ECMO, the later you do that, the less chance of survival it is. So my takeaway from this was actually not that every patient needs ECMO, but that a patient with myocarditis who requires intubation, we should be thinking about, are we prepared to provide the next set of support that the patient may require? And if so, how are we preparing for it? How are we looking for it? And what's going to be our threshold for initiation of ECMO? Those are really important and center-specific conversations to have, depending on your situation, your setup. But to me, those are critical things, because if we are ready to intubate a patient with myocarditis, we better be ready for resuscitating that patient or doing CPR on that patient. Certainly, once you get beyond that, you can support the patient on ECMO or assist device, whatever is available to you. Just to know that patients who require support still have a very good survival, a greater than 60% survival to discharge. So I'm still very optimistic when these sick patients can be well supported in a timely manner, they can have excellent outcomes. So bottom line is, if you quickly recognize myocarditis and a sick myocarditis, and if you're not a center or an emergency room that can handle the next steps, early transport should be considered for these patients, because there is nothing like transporting a myocarditis after 2 days of being sick in a hospital to an ICU later. Usually those do not turn out well. So I would request that if you diagnose a patient with myocarditis, the early transport to a center that can actually care for that patient is very, very critical in saving the life of that child. Just to summarize quickly, the pathology is triphasic. There is viremia. There is role for the coxsackie receptor that helps the viruses get inside the heart. The viremic phase is followed by inflammatory phase that leads to an immune-mediated phase, which can turn into a chronic stage, even after the virus has already cleared out of the body. The diagnosis is clinical always. Viral PCR has a very important role, And biopsy, to me, is the critical and continues to be the gold standard for diagnosis, as you just saw in the AHA statement, and allows you to specify the diagnosis, including differential diagnosis such as eosinophilic or giant cell myocarditis, which can require very different treatment. For therapy, IVIG generally is beneficial, and that's why we use the word probably beneficial. In our practice, we will use IVIG if the ejection fraction on admission is less than 45, or if you have evidence of ventricular ectopy. To me, that's a very important marker of myocardial irritation, that patient can deteriorate quickly. So if we see ventricular ectopy on the telemetry, we would not hesitate to give IVIG. And you have acute inflammatory markers in addition to elevated BNP or troponin. Again, I would think about IVIG. Early stabilization and early support at an appropriate center is critical. And finally, just to reiterate again how important this is, quick recognition of myocarditis, stabilization the best you can, but then transporting it to a center that can manage myocarditis appropriately is the most important step in my view. And with that, I want to thank you again for the opportunity. Hope this was a useful summary, and I'm happy to take questions, and I can stay on as long as there are questions. I have no constraints with time. Thank you again. Thank you, the organizers.
Thanks a lot. Thanks a lot, Dr. Shuprasad. I'll read for you some questions from the chat.
Sure.
Someone is asking, apparently healthy child with resting tachycardia. What investigation should be ordered? Is it PNP?
Yes. So if you have resting tachycardia in an otherwise healthy child or a previously healthy child, let's say, to me, the most important question you're trying to ask is tachycardia coming from the heart, or is tachycardia a response to something that is going on systematic, rest of the body, So to me, for that, BNP is the most sensitive marker. And even in infants, we use it even in newborns, it'll immediately give you a separation, an algorithmic separation of thought and say, well, this patient has resting tachycardia, but the BNP was essentially normal. In our lab, a pro BNP of 1,000 is normal for that age, and the BNP came out 900 or 1,200. That is normal or within normal range. I'm not that worried that the heart is eminently sick. I can take my time and look at other systems and other reasons of resting tachycardia. But that same child, you're thinking about something with the heart, you get the BNP, and again, the turnover time for BNP is 1 minute, 30 seconds. You can get it instantaneously. And you get the BNP back, and now the BNP is 25,000. You're very clear that this child has something cardiac going on, and I need to get an echocardiogram instantaneously, or I need to transport the patient. I need to call the people I need to call, and I can do everything else afterwards. But let me make those phone calls first so I can get a stat echocardiogram or something. So it allows you to, and when we have published a couple of these papers in terms of separation value of BNP. BNP is not going to be subtle. It's not going to say, well, it was 1,100, so we ordered an echo. When it's concerning, it will tell you a clear message. BNP will be 5,000, 50,000, greater than 25,000. It's not going to be subtle. So to me, it's very, very important. I'll answer the other question that is important with this. Bradycardia may be a sign of myocarditis. Yes, absolutely. I think we have published papers where kids have presented in heart block as the main manifestation of myocarditis. The AV node becomes so sick, as you know, that bradycardia may be manifest. And you're right, a disproportionately slow heart rate should also worry you. Child looks sick and the heart rate is 60. You're very worried about that 3-year-old. So you're absolutely correct. Yes, bradycardia may be a sign of myocarditis. Absolutely.
Okay, there's another question for fluid resuscitation in suspected myocarditis requires caution while maintaining adequate perfusion. for the blood pressure is important. What is the approach in this situation?
Unless the patient is dehydrated, any fluid administration has shown zero benefit in these patients. Let me say that again. Unless the patient is dehydrated, fluid resuscitation in an acute suspected myocarditis has shown zero benefit. So our job really is to say, can we correct anything else for this patient? And if nothing else, do we need some inotropic support for these patients? But
Yeah.
when you want to support the low cardiac output in a myocarditis, remember how the heart is feeling. The heart is feeling swollen and inflamed, and the volume you give, like I suggested, does not circulate in the body. It just goes to the what we call the accommodating chambers, like the lung and the liver, and it just sits there. So fluid resuscitation does not translate into increased intravascular volume, that is circulatory volume. So therefore, it is not beneficial. I would say stabilize the patient, correct the electrolytes and acidosis the best you can. And if nothing else, use gentle inotropes. We generally use inodilators like milrinone or dobutamine if the heart rate is not too fast. And if nothing else is available, low dose epinephrine. Just monitor for arrhythmias in those patients. But those are whatever is available for you is okay.
What about maintenance fluids? What's your recommendations about how percent from the maintenance fluid would you recommend
Yeah.
patient with myocarditis?
Yes, absolutely. Maintenance is fine because again, you're going to keep that
Full
patient nil
maintenance.
by mouth very likely.
Mhm.
So that is okay, but using resuscitation is probably not.
To give full maintenance, or it's recommended to give like 60% or 70% from the full maintenance?
Yes, generally what happens is we're using the inotropes fluctuate so much, and you're giving all other things, including, for example, IVIG, which is a very big volume in general. So we would choose to be at half to three-quarter maintenance, half maintenance in older kids and three-quarter maintenance in younger kids, less than 10 kilos. That's what general rule of thumb we would use. So less than 10 kilos, we would use half maintenance. Sorry, less than 10 kilos, we would use three-quarters maintenance. Above 10 kilos, use half maintenance fluid. And then
Okay.
use the other medications.
Some other question. In pediatric cases, what clinical and laboratory markers make you decide early to start IVIG or immunotherapy?
Yeah, so IVIG, again, the most important thing that we use for the indication for IVIG are one, ejection fraction, so an echocardiogram that does show decreased function. We would like to have that before we start IVIG. We don't want to give IVIG if there is a large pericardial effusion, for example, right? So we definitely want echo done before it. And generally, I use echocardiography, less than 45% ejection fraction as number one thing. Two, I want to be sure that the patient is still in an acute stage of viremia, right? For IVIG or acute stage of inflammation for IVIG to be beneficial, either acute viremia or acute inflammation. So
Yeah.
we would want either a PCR that is positive. So you come in and you do a nasal PCR and you tell me that the patient's positive for adenovirus. That's helpful. I want to use IVIG. Or I want to use IVIG when the inflammatory markers are very elevated. So BNP is high, CRP is high, and that is telling me there is still an acute inflammatory process that's causing myocardial injury. I would use IVIG. And the third marker for IVIG use is ventricular ectopy. So if the patient's already having premature ventricular complexes on EKG or telemetry, I would want to use IVIG early in that patient so I can calm down the inflammation.
How many days would you recommend? Do you recommend the dose of 2 gram per kg over
Yeah.
2 days or 5 days?
Generally 2 gram per kilo divided in two doses. So we just give 1 gram on the day one and the second gram on the day two. So just 2 grams per kilo over 2 days, basically.
Could we repeat the IVIG once again if the patient is not improving, and after which period we are we're going to repeat it?
Yes. So for general myocarditis patients, I have not repeated doses of IVIG. I think if the patient because as you know, the half-life of IVIG, once administered, you are going to have some beneficial effect of it for the next 48 hours, even after completion of the dose. And on day 4 or 5 of the myocarditis, let's take a step back. What is the natural history of myocarditis is that the acute phase only lasts for a week, right? And if on week 2, you are already seeing that the myocardium is still inflamed, still decreased function, in general, that is a very worrisome sign. Rephrasing it, if by 1 week the heart is not showing recovery already, that's a very worrisome sign. At that time, I would really want to have a biopsy diagnosis if possible before repeating IVIG, because maybe I'm not treating the right thing. Maybe this is an infection that truly requires something very specific. So we generally want to have a biopsy. Let's say we don't have access to biopsy and it's week 2 and we have no other therapies available, maybe then I would use a second course of IVIG. But in general, I'm reluctant to use repeat IVIGs without confirming that I'm just treating regular lymphocytic viral myocarditis and I'm not dealing with something exotic. So it's very rare. Obviously, if it's in the COVID era and in the Kawasaki disease, we've used a lot of these repeated therapies. But in traditional myocarditis, I'm hesitant to use a second dose of IVIG.
Okay, and the last question, I know we have exhausted you too much. What about steroids? Would you prefer a pulse steroid, or what regimen of steroids would you recommend?
Yeah, and if it's okay, I do want to quickly show you that slide because I purposely ignored the steroid component of our study. But to me, I think it's helpful to quickly look at that one slide. Okay. So if you look at the last column, there is a small cohort of patients that did receive IVIG and steroids, and a very small that received steroids only. So using steroid only in the 6 American centers that we studied here was very rare. Most of the times people used either used IVIG alone or used IVIG with steroids, So that's at least 38 patients there. And what you saw was that the steroid alone cohort or IVIG plus steroid cohort had, again, slightly higher mortality by numbers. P-value was not significant. But if you looked at the mortality, 2 to 3% versus 8% here and 14% in the steroid alone. Not enough patients there to support a statistical difference, but clearly the signal showed that it was not very beneficial to add steroids. So unless we're dealing with either eosinophilic or giant cell, use of steroid has not shown to be of clinical significance in terms of resolution of myocarditis. It makes us feel better when we add steroids, but there is no data that has actually supported the use of steroids in sick patients with myocarditis. So again, if you're having to use things like steroids, which may actually have some harmful downstream effects, I would want a confirmation of diagnosis before we jump onto steroids.
Thank you, Dr.
Yep.
Shukran.
Well,
Thank you. Another question. Fluid resuscitation in suspected myocarditis requires a cushion, while maintaining adequate perfusion pressure is important. What is the approach in this situation?
Yeah, like I suggested, yeah, absolutely. And then, like I suggested, I think the in pediatrics, unless the patient comes in dehydrated, we see no role in fluid resuscitation in a patient with myocarditis, or for that matter, any other reason for acute decompensated heart failure. There is no role for fluid resuscitation. Not one patient has benefited from the use of fluid. It makes us feel good, but it never benefits the patient. And I would actually think that it hurts the patient. So our role is to maintain adequate perfusion, by that adequate cardiac output. And therefore, I would rather that you use a low dose epinephrine drip, or if the patient has adequate SVR, by that blood pressure is okay, use milrinone or dobutamine. In general, we would prefer milrinone. We would start at a very low dose, 0.25 per kilo, go up to 0.5 per kilo and keep the patient there, 0.5 micrograms per kilo per minute. That's our preferred agent. If the patient's heart rate is okay, not too tachycardic, we would certainly use dobutamine as our next best agent. If the patient has a low blood pressure as a part of low cardiac output and low syndrome, then to get the patient to be a little bit normotensive, we would use either dopamine or norepinephrine. Both are okay if the patient is hypotensive, just to get them to normotensive range. But if the patient is normotensive, then try and use an inodilator more than anything else. And if the patient has ventricular ectopy, we keep lidocaine very handy and have very low threshold for starting a lidocaine drip if required, if the patient is showing ventricular ectopy. Now, that patient is also telling us that the patient is getting sick very quickly, like within the next 12 hours. And so you better have all support mechanisms ready, including transport to a appropriate center. And then just quickly, in terms of sedation, if you were to, again, the key is to have experienced providers. The physicians need to be experienced in intubating a sick cardiac patient. Generally, I prefer ketamine as the sedation agent. But if you are experienced with etomidate and that's what you want to use, it's okay. Key is to use an agent that you are comfortable with. My agent of choice is ketamine, and that's what I would use. I'd use 1 per kilo, 2 doses of ketamine, and then use whatever else you have handy, including just straight going to rocuronium, paralytic agents. And then when the patient's waking up, give a little dose of Versed or something when the patient's waking up from intubation. But going into intubation, just single agent, ketamine, and rocuronium, followed by anything, any narcotic, and Versed as you're waking up after intubation's already achieved. That's my agent of choice. But if you're comfortable with etomidate, that's okay too. And for IV fluid maintenance, it doesn't matter, age dependent, normal saline or Ringer's lactic. And then for little kids, half normal saline DNS, D half. And like I mentioned, if you're less than 10 kilos, we would use 3/4 maintenance. If you're greater than 10 kilos, I would use half maintenance fluid.
Thank you.
You're welcome.
On behalf of the Egyptian Foundation of Egyptian Pediatricians, thank you very much for this wonderful lecture. We truly appreciate your contribution and hope to welcome you in Egypt soon.
Of course,
Thank
most
you
welcome,
very
and
much.
it's a really honor and a pleasure. Thank you so much. Bye-bye. Bye, everyone.
Thank you. شكرا.